All right. Good morning. We just had coffee, guys. Come on. Good morning. Thank you. All right. Really excited to get started. By way of introduction, my name is Abdul. I'll say it. I am from the great state of Michigan and privileged to have served in the city of Detroit in a number of other roles. I'm really excited about this panel today. We have four incredible people who have a lot to share on an issue that we ought to be thinking about as centering in any conversation about the work of public health and healthcare. I always feel that people do a better job introducing themselves than I ever could introducing them. So I'm going to go ahead and jump in, and what we're going to do is start with Dr. Chelsea Bond.
Oh, thank you. Great. So my name is Chelsea Bond. If I introduce myself in a cultural context, I say that my Bond is my married name. I was born a Wadigo, which denotes my South Islander ancestry. I'm a Malanjali woman. I belong to the Yugambeh language group in what's known as Southeast Queensland in so-called Australia. I've started as an Aboriginal health worker. I came to health with an interest in ensuring that our people live to be old. And I thought health was a vehicle which I could play in and to do some work around. I'm an academic doctor and I'm a mother of five. I am on the board of a community-controlled organisation within my own community, which doesn't do any clinical sex provision, but it's where my best health work is located. I'm really interested in contesting claims of benevolence of public health. And I'm somewhat cynical about that universal healthcare will operate in the interests of Indigenous peoples. Worker for Non, who notes that health and medical science has always been imposed or proposed by the occupying power, so that going to see the doctor, the mayor, the constable, the administrator are all identical moves. And so as a black woman, which is for some might be hard to see me in that sense, but in my context we talk about ourselves as black fellas, I can testify to the brutality of the health system upon my body and upon my loved ones. And so I'm really interested in how we might bring a critical race take to public health and kind of interrogate this claim of benevolence and altruism.
Thank you. Dr. Hinemoa, Elder.
Kia ora no tātou, ngā mihi nui o te wā. I met many of you last night. I hail from the far north of Aotearoa, New Zealand, and I'm a mother of two. I'm a child and adolescent psychiatrist, and I wear a lot of different hats. As you may know, I'm the only Māori identified child psychiatrist in Aotearoa right now, and so I have a lot of responsibilities. I think ethically, for me, it's really important to carry on working clinically, even though I'm constantly kind of scanning myself for to what extent I'm part of perpetuating the problems and trying to make sure that I work towards making things better for our people. I certainly resonate with what my colleague is saying around interrogating the benevolence of the public health system. So one of the things that comes to my mind is that the cultural competency arena is one area where clearly Indigenous peoples are invisible often, actually. So the American Academy of Child Psychiatry published a practice parameter in its very influential Orange Journal. I'm a member of that august body. And I felt I couldn't step away from critiquing the cultural competency parameter that was published at that time because we couldn't be seen within that. So, yeah, I have a lot of thoughts about the questions that are going to be raised on the panel this morning, and it's a great privilege for me to sit here before you. Kia ora.
Thank you. Dr. Nadine Karen.
Good morning, Nadine Caron. I'm from the Sagamok First Nation, which is an Anishinaabe community in Northern Ontario in Canada. I actually now live in Northern British Columbia in a community that serves rural and remote populations. I'm here with my husband, Patrick, and my daughter is at home visiting Quebec, of all places. It's an absolute honor to be here, and I've been communicating with some amazing people that I've had the honor of meeting already, Rhodes scholars, senior scholars, starting scholars, alumni, and of course the panel here. And it's really interesting and something that I had to even grapple with in terms of having an Indigenous health panel at Oxford. To come to England and explain to my Indigenous colleagues back in Canada that we were going to be having this amazing discussion. And I know it's going to be amazing, but it was something that, one, it was something to reconcile with, and it was also something that was my colleagues were very impressed that this conversation was happening across the ocean. And just after I spent a day at the University of Toronto giving a lecture on the history of Indigenous peoples in Canada, talking about the role of determinants of health, explaining that in my mind and in multiple scholars' minds, there's actually the determinants of health that are applicable, and then in the context of Canada, Indigenous specific determinants of health that do not apply to the non-Indigenous populations in Canada. And at the top of that list actually is colonization, the legacy of Indian residential schools, the federal policies of assimilation, and so it's been a journey, and I'm so excited for this. Overall, I would say that if I was introduced, this is how I'm often introduced in Canada. Nadine Caron, the first female First Nations woman to graduate from UBC School of Medicine. Nadine Caron, the first female First Nations general surgeon in Canada. Nadine Caron, the first this, the first that. And it's really fascinating because it's usually given as a badge of honor, but I'm willing to bet my colleagues here will say that it really is, I think, sometimes you wear a badge of honor, usually it's a medal around your neck. Badge of honor a lot of times is more something that you wear to give a message outward. And I would say that it really is, when I went through medical school, my husband and I went through together, we took the same exams, we had the same curriculum, we had the same goal, and we both graduated. We did nothing different. And so to celebrate me on the day of graduation, to say that I was the first, was one, a real crux time to decide, do we celebrate this, or do we start to examine the failures of the society in which I had done it? And I think that's a really delicate balance. And I think it's a really delicate balance even for the Rhodes Scholarship Program, for the Rhodes House, for Oxford to even look at, to start to wonder. I just asked the panel, I said, are any of you Rhodes Scholars? And interestingly enough, none of us are. And I'm just so honored to be here in this brilliance and this open conversation, because the people I've met in this journey so far, I know are open to this discussion. And it's like in many of the situations, I think we're going to be talking to a room full of the converted, because you're open and you're wise and you're brilliant, and you have put together, especially Melindy and the organizing committee have put together this panel, of which I'm incredibly honored to make which.
And then thank you so much, Dr. Roxanne Bainbridge.
Yeah, well, I'm Roxanne Bainbridge. I'm a professor of Indigenous health research, so firmly positioned in research. I do no teaching, I have research students. My family comes from southwest Queensland, so not too far from Chelsea. They're around the Charleville Mitchell area, Roma area. My family are the Gungari Kunya nations of that area. On my mother's side, she is Scottish, so I have two different heritages, very different, caught in between as I grew up. I think that was a blessing in disguise, really. As I grew up, I think I become a bridge between two different groups of very different groups of people. In my work, I am the director of the Centre for Indigenous Health Equity at Central Queensland University. The kind of research we do is community responsive research, depending on what they do. I don't have a niche area. I respond to the needs of community. So very much community-driven work, whether that's child and maternal health, or palliative care at the other end of the scale, I guess. Health systems research, health services research is up to what people need. So it's very much responding to community needs. I'm very interested in the idea of universal health because I think it feels like it's the holy grail that's being put out there right now, and I guess that might be the case for people who don't have that, but certainly we can attest to the fact that it hasn't benefited us in the ways I think everyone thinks it will work for all populations. So I think that that's an important area of inquiry. But really it's about, I really want to get the evidence around, different evidence around reform in the research space, so talking about decolonising the way we approach research and having research for impact, and not impact that's defined by researchers, but impact defined by the people we serve. I guess that's me in a nutshell.
So I really appreciate the introductions. Some of the themes that were hit on had a lot to do with power and who gets to have power in the institutions that we work in and we work with and we work under. And I want to hear what your thoughts are. And Chelsea, you raised a really interesting point about whether or not these institutions actually serve us all that well. Can you expound on that a little bit?
Well, even in the previous session, it was great, but to talk about maximum benefit for the most often means violence for Indigenous peoples because we're not the most. In my country, we're 3% of the population. In order to go from 100% to 3% in like 200 years, there's a certain kind of violence that's perpetrated on blackfellas in order to make that possible. And the health system is complicit in that. There's no question about that. The evidence is there. So I'm interested in revealing that. What's a real challenge, I think, though, is that we know in Australia we're residing over, one of the largest racialised health inequalities in the world. Yet we can't talk about race as a field of inquiry. We don't have critical race scholarship in Australia, period, let alone within the health sciences. Now, if we look at violence against women, we don't suggest that you can't talk about violence against women as a way to solve it. Yet when we talk about violence against blackfellas in our country, apparently we can't talk about it. So I came from working in a community context to working in the academy because I was interested in the production of racialised knowledge, and particularly by the health sciences, particularly by public health. Because when I came to study health and I got to read the text produced about us, it was violent in what it said about us. The fact that we still see as a risk factor along obesity and smoking on most health promotion material as a public health good, that's deeply problematic. So I see myself as an Indigenous person working in the academy is to contest the knowledge that's produced about us and engage in intellectual warriorship. So I'm not here to be an alibi to the health system. I'm not here to testify to its, altruistic motivations. I'm here to reveal its brutality in order to make it work for our mob so that my 5 children, they don't know a grandfather. They don't know a grandfather. So I hope that one day they'll become grandparents.
That certainly resonates with what's happening in New Zealand too. And at the same time, it's a different history of colonisation, different scale. But certainly I see some of the manifestations of colonisation as happening in the here and now. So colonisation is not something that happened in the past. It's something that, we look at in museums as some sort of exhibit. This is something that we live daily. And so the couple of examples that come to mind around how research is also, and how research is complicit in this, is the money that's spent. So on one hand, we have extremely good detailed evidence of the disparities of the needs of our Māori community. So we are about 17% of the population, but more than 50% of people in prison are Māori. If you're treated under a compulsory treatment order and you're Māori, then you're 6 times more likely to be treated against your will than a non-Māori person who has the same diagnosis and the same severity of illness and the same treatment. So just to give you a couple of examples. And yet the research monies are very limited. So in terms of one of our major funders, the Health Research Council of New Zealand, which spends between $90 and $100 million a year on research. More than 60% of that money is spent on biomedical research, which, and I'm one of the public health co-chairs of the public health committees which scrutinise the proposals. So, in fact, when you dive down into how accountable and responsive our researchers have to be, yes, they have to fill in a section on Māori health responsiveness, but that is the only section in the proposal which is not given a weighting score. So, in fact, that promotes tokenism. It means that those researchers really don't have to deliver knowledge, information that has any impact or that has some potential for transferability into really making a difference for Māori families' lives. So I think we're on two sides of the ocean, but we have very distinctive histories, but we also have some similarities.
Across the pond. Yeah, it's interesting. It's like you could be talking and just from a First Nations down the street, and so much of it would sound very, very similar, which makes us great allies. It's great to sort of share solutions. But in terms of research, I think that's certainly another issue, and it's not any different in Canada in terms of our Canadian Institutes for Health Research, Genome Canada, the Terry Fox Research Institute, some of these national organizations, but then also the provincial ones or state-based ones, also very similar in terms of the disparities in the distribution of resources. And there's, the 4 pillars of research. Again, same thing, most of it, like a bulk of it goes to biomedical, and I'm not here to argue that, but one of the things is when you look at something as a healthcare provider, even in the world of surgery, I see the area of, like I do cancer surgery, so I see oncogenomics absolutely revolutionizing the care that my patients are going to be given, the risk stratification, the diagnostic tools that we have. It's amazing. It's precision, and it changes individuals' care on a patient-by-patient basis. So the idea of generalizability is maybe perhaps more questioned, especially when it's almost 100% reliant on it when it comes to Indigenous populations. So last year, a group of us just applied for a grant, and we called it Silent Genomes, in reference to the fact that for the most part, Indigenous peoples are really silent in the area of genomic research. And it's a multi sort of pronged research project that's looking at entities, everything from the lack of access to the application from a medical point of view, like the clinical point of view, but also the fact that if you look at something like NOMAD, which is a reference database that includes like 130,000 human genomes, like whole genome sequences, and it's what medical geneticists use as the tool to diagnose their patients. There's not a single Indigenous identified within that entire 150,000 people. And so when an Indigenous child with a rare disease, for example, comes in with a potential genetic disorder, the medical geneticists just hope that this, they go through it, but they recognize that the likelihood of diagnostics success is dramatically different, a massive disparity, but no one's addressing it. And not only is no one addressing it, but one of the things was, it was a Genome Canada grant, CIHR, and so they did arm's length review. So the reviewers, none of them were Canadian. But we had like these sort of individual panels that we had to go through over the phone, on teleconferences, and these were reviews before the application was sent in that were supposed to help our application. And I remember on one phone call, there was about 8 people on the other end of the phone from somewhere across the world. And one of them actually said, Dr. Caron, we understand you're passionate about this, but from what I understand from the research and the statistics of the disparities of Indigenous people in Canada, your people are just killing themselves. Like through suicide, whether it's accidental deaths, whether it's homicide, do you really think that Indigenous peoples in Canada really are ready for this type of genomic research? And these are people that are on the international review panel to actually assess whether we have scientific merit. I didn't realize when I put this application forward that it was going to be on a moral merit that I would be fighting for. as opposed to the scientific legitimacy of it. So those are some of the things. And so when you talk about determinants of health, what came up in my talk again was not unique to Indigenous people, but I would say that what we often forget, and I think in a room full of scholars, that I think access to health research is a massive determinant of health.
And that's the thing, I think in health sciences we've come to the understanding that race isn't real biologically, but the racialized logics are an everyday practice within health and health research, and it doesn't matter how intelligent someone is, there is still this commitment to race. Because that's exactly what that is. And if we want to speak out against it or name it, then somehow it would be political, not intellectual. And so for us, we're still fighting to be able to have this conversation and still attend to the fragility of white people who mean the best for us.
Sure. We're the ones accused of being political, but in fact, the other side of the conversation is highly politicised also.
Yes.
So I'm just claiming that the role of black speed bump in the course of my daily practice. Because that's kind of what is inscribed upon our bodies every day of being the troublemaker. And so why not claim it? What's the point of being a scholar if it's not to contest ideas in the everyday? That's why my ancestors put me in this place.
Exactly.
Roxanne, you as a researcher, how do you see the directions we need to go, given a lot of these criticisms? What are the directions that we can go to make a more inclusive, equitable kind of research enterprise? What would, if you could architect it, how would you change that? What are the ways that it would impact the questions that we ask, the data we collect, the way we review studies, the access that we have to it?
It's all about power, obviously, but Professor Farah spoke about walking with humility and crossing boundaries. And I think that's probably the first port of call. People can't relinquish power, they can't share power, and we're always on the other side. And like Chelsea said, we are always seen as troublemakers. Should we say anything? But if people could just walk with humility alongside us, understand their role, their position, I think we'd go a long way. But, it starts at the top. We've got a system of health research that purports to value Indigenous health research, but it's totally and completely controlled by white researchers. Even in 2019, we have 5% of funding from the National Health and Medical Research Council that goes against Indigenous health research. Only 4% of that 5% is led by Aboriginal and Torres Strait Islander researchers. That's a problem in itself at the highest level, and that just filters down. And I think, traditionally, research has never been done in our best interests. It started out about, the curiosity with the exotic other. It moved to, I guess, documenting a dying race for history and scientific knowledge. It moved to protection of white populations, even though the diseases that we had were introduced by them. It was about the protection of white people. So when does it come to, and now it's about what we can do for people, not me, what white researchers can do for people under their terms. So that idea of walking with humility and crossing boundaries brings a whole different argument and context to what Professor Farah was talking about.
And Roxanne, was a few years ago, there was the NHMRC, our National Health and Research Council, put a special call out for an Indigenous health researcher capacity building initiative of $1 million. And there were 14 shortlisted, 3 led by really prominent Indigenous health researchers who have teams of Indigenous researchers. But the bid went to a non-Indigenous woman who was leading a research team of which there were not active Indigenous academics on that team. What was interesting was the CRE was for Indigenous health researcher capacity building. But what the funding went for was a research centre that was focused on Indigenous alcoholism. So even in the task of trying to develop Indigenous research, as we see the reproduction of racialised knowledges by the drunken Aborigine. In that was like 2016 or something?
2016, yes.
Yeah.
Yeah.
You know, another interesting fact that we followed in your footsteps in Canada. So we said, look what Australia does, look what New Zealand does. And so we really lobbied the Canadian Institutes for Health Research to ring-fence funding to say, put this aside. And now we're running into, so we get to have those problems now because we have money. No, but at least there's this pocket of money. But the other thing that's interesting is there's more and more pressure for the national funding agencies to leverage funds. So you put your budget forward, and this is going to be $1 million grant, and we will give you $500,000 if you can find the leverage funding for the other $500,000. And what is fascinating is when I was on the Governing Council for CIHR, again, you know, they have to. The only Indigenous person, so you go around the room and everyone thinks this is a great idea, and then all of a sudden you're sort of there. In CIHR, or Canadian Institutes, there's 13 institutes, one of which is the Canadian Institutes for Aboriginal Health, now the Canadian Institute for the Institute for Indigenous People's Health. And so that's one of the 13. The other 12 are actually applicable to every Canadian. So the example I gave was there's the Institute for Cancer Research. And I asked the board, and I said, you know, who here has had cancer, has had a loved one who has had cancer, or is scared to death about getting cancer? You know, and so everyone in the room puts up their hand. I said, who here is Indigenous? So no one puts up their hand. I said, who here might become Indigenous, is scared of becoming Indigenous? So it's really hard to leverage funds when you're trying to bring, like when it's in their backyard, when it's something, whether it's aging or whether it's palliative care, whether it's cancer, whether it's genetics. It's so easy to pull in those funds. But when it's something like Indigenous, all of a sudden you have to sort of legitimize it. You have to find whether it's funding agencies or philanthropists, you have to find people who understand that history, who understand the benefit, who understand the impact that this is going to have, and recognize that the other thing is things can translate. So believe it or not, I honestly think some of the research being done with Indigenous peoples or by Indigenous peoples, I think we're going to have solutions that we're going to be able to translate out to the global health, public health world, and we are going to be able to help, even if it's us doing the research or on our populations with our people. We will find solutions that will benefit global public health if you let us.
I think one of the key things is many of us have decided in New Zealand we're not going to wait for the government, we're not going to wait for funding. We're just going to find ways to go out and do it, do the right thing the right way by our own people, and use whatever spheres of influence we have, regardless of some of these fundamentally racist structures, to answer the questions that our communities want answered in the way that they want them answered. So I spoke last night a bit about the school that the Brain Research New Zealand is involved with. So, in fact, even though I'm in a brokering role, in my strategic leadership role there between a non-Māori organisation, which is highly seductive. You know, it's about neuroscience, so it has all those sexy factors and people want to give money to that. Actually, I'm in there creating a quiet revolution because I'm appropriating that time and energy for our young Māori to come in alongside to influence, and at the same time, I'm tuning into what they're saying they need and looking for other ways to link them with Māori structures, with tribal structures, where they can get their needs met in other ways that don't get so complicated and fundamentally hampered and held back by these systems that are really not designed to actually serve Māori health advancement. That's more of the box-ticking part of the system.
I think that's, for me, I've now, early days of being a health worker, it was all about cultural awareness and appealing to be seen as human and appealing to via our culture as well. And now at the point I'm interested in producing the kind of scholarship that makes it possible to make the state accountable for the brutality they visit upon us. So I'm interested in critical race in terms of how do we use the justice system to get health justice for Indigenous peoples, and how do we have a language of health justice rather than close the gap, rather than saving the Aborigine. So I think there's a really exciting space for Indigenous academics to produce the work for our activists, our lawyers, to hold them accountable and to make them pay, because I find we don't get change by appealing to our oppressor. We have to hold them accountable. And I think we have the power and the capacity, if I use that word, to do so. And so I'm really interested in how we build our armies of Indigenous warriors, do the work in the academy that's necessary to change the everyday lives of Indigenous peoples, both locally and globally.
And what do you see as the pathway for non-Indigenous allies to be supportive? What are the roles that folks play? Because I heard a lot about cultural competency, and I come from the immigrant health side, which ironically is mostly colonized people moving from the place in which they were colonized into the places that were colonizing, which creates a very interesting sort of way of thinking about the world. The French soccer team is largely African, and so I guess the question becomes, we think a lot about how do you engage? What would the ideal space be for, just given the mass effect of numbers, for allies to be supportive of the work that we do? How do you see that playing out when it comes to Indigenous health?
Can I say, often that's the focus and that's the problem, that becomes the first question when we speak about the human oppression. But the easy thing is just get out of the way. Hand the mic over, give the seat over, step away from the table, and let the people who are supposed to be there sit there. It's really simple. It really is. It's not that hard. And I know myself, even our protocols, I can't go and take a seat at a table on a matter that I don't have a connection to in some kind of way. It's shameful. You don't do that. So I get asked all kinds of things. I go, well, no, it's not my place to do that. That's someone else should do that. So I don't understand why it's that difficult. But apparently power is not readily handed over, it seems.
No. I mean, in my areas of work, I can see a real need for ensuring that we have culturally competent non-Māori workers in mental health and youth justice and care protection. And we do have some robust systems for that. And I think one of the key issues is cultural competency begins with self-reflection of whoever the person is themselves. Cultural competency is not about collecting lists of ways to be and talk to and listen to people from diverse cultures, as if these are sort of drop-down menus of cultural requirements. Actually, cultural competency starts from within the person and knowing their own history and their own value system, from which you then relate to anyone else, actually. So we will never have enough Māori psychiatrists, Māori mental health nurses or paediatric nurses to serve the needs of all of our people. So we do, in general, take the approach, well, how are we going to enrol champions from other cultures to sing from the same hymn book as us, to come alongside us? There are programs, so the College of Psychiatry, we have requirements in that training program. We have some excellent, well-heeled, well-respected senior elders from our Māori community who deliver those programs. And so I'm pleased to see that maybe in the last 5 or 6 years we've moved forward. There was a bit of a stalling process where the evidence for cultural competency was really contested by the non-Māori aspects of some of those power-holding entities. So I think the issue of what is regarded as valuable and valid evidence is often the thing that's brought up for question. Oh, well, is that Māori stuff, we'll get to the real science. That's the Māori stuff. But what about the real science is often something that comes up for me from colleagues that I think are really much more on board than they actually are. So in New Zealand right now, there is a lot of work going on in cultural competency for our non-Māori colleagues, and I think it's an important part of the puzzle.
Can I ask you, Phyllis, do you use the same term like cultural competency as cultural safety? What's
That's a really good question, because in Canada, we're at a great stage where I think it's really important we've gotten the ball rolling, and I think it's really important to get it to the top of this hill that I feel like we're pushing it up. And I think that we have a way where if we give up, it's not going to get to the top of the hill. If we get there, I think we're going to see, I'm very optimistic. We actually don't use the term, and we meaning in my circle of colleagues, and certainly in British Columbia, we no longer use the word cultural competency. We actually say that is on your way to end results that really are the expectations of the Indigenous peoples, which is cultural safety and humility. With cultural safety being really that definition of a space where at any given encounter, for example, between a physician or healthcare provider and their patient, that the patient feels safe, that they feel the hierarchy of power is the patient has a choice and they can ask questions. They have a right to say they don't understand. They have a right to an interpreter. They have a right to demand respect. And actually that safety cannot be defined by the healthcare provider saying, I did a good job today. It actually has to be defined by the patient. And then cultural humility is a process that continues. As you move forward and realize that it's not something you're ever going to master, and I won't master it. As an Anishinaabe woman, I will not master it living in northern British Columbia, where I work with carriers, Sakani and Haida, and patients from a wide variety of Indigenous populations. But I am on board with respect to the need for this education shift in the health sciences. And so at the University of British Columbia, our Center for Excellence in Indigenous Health worked hard to push this forward. We used the Truth and Reconciliation Commission report and the calls to action. Every time we got sort of pushback from a university that said we can't put 8, 10, 12 hours of new curriculum in when we're pulling out anatomy hours and we're pulling out physiology hours, we can't put it in. We just said basically you can't afford not to put it in. You are a Canadian institution. You're responsible for creating healthcare professionals that are capable of working in Canada. That means by definition that they must understand the people of Canada and the unique needs of population they're going to serve, which means the ability to provide culturally safe and cultural humility in the context of their patient care. And so a lot of it is the truth and reconciliation is the truth and the reconciliation. So a lot of that is actually teaching our medical students, nursing students, dentistry students, speech and audiology, midwifery, social work, counseling psychology, the actual truth about the history of Indigenous peoples in Canada. And you would think that would be pretty basic. Unfortunately, for the most part, the overwhelming response is the absolute shock of the history of our country and what they didn't know and what they didn't understand. And all of a sudden, I think that in itself is so empowering for allies to form when they realize what their Indigenous patients and their families have gone through and why they need to tread softly in whatever world they're in.
So I think, go ahead.
Oh, sorry. I think obviously I agree with the rest of the panel, but I think that thinking about cultural competency and whatever you like to call it has never been clearly defined. I think it's, and what has come to light is that it operates at different levels. So you've got the patient health professional encounter, but you've also got the level of the systems, the big, larger health system and the organisation, service level, and the health professionals. So you've got a few different levels, and of course then you've got the role of the university in producing culturally competent, if you like, health professionals. So I think, and if you don't take in all of those levels into account when you're trying to address it, it's not just about getting health professionals out into the services, and next minute it's like, well, that's not working out. Let's bring in a local. That specifics is very, very important. But, you know, cultural competence is about behaviours, attitudes and practices and policies. So it has to happen at all of those various levels and be enshrined in that policy to filter down, and that starts with leadership at the top most of the time. So I think, you know, across all institutions, and it's not our responsibility. We are not responsible for changing all of this. I am so sick of being the one responsible for everyone in the world. So I'm very happy to be responsible for our communities, of course, but I'm not responsible to change everyone in the world that wants to come in and do good in communities and in health services. So I think, you know, there has to be a meeting in the middle where people start to come together and start to listen and be happy to relinquish some of their power, and because it still exists. It's in the systems. It's a Western system. Our health system is Western. What do you do with that? You know, it really does require big changes, and it has to filter down from the top and start.
And I'm not convinced the health sciences know how to really deal with culture properly.
No.
So I don't trust the health. Having been a student of the health sciences and public health, having, you know, taught med students and looking at curriculum, health sciences, culture is something that the health sciences have used to rationalise health inequalities, to explain it away as somehow our ancient practices prevent us from making better health choices. However, so I'm interested in health humanities and how we could kind of develop Indigenous health humanities, capable of asking and interrogating the health system. Because having been in health faculty and then moving across into humanities, the kinds of questions I get to ask are very different when I'm sitting outside of the health sciences as opposed to being within it.
Yes.
And so I think there's an opportunity for Indigenous peoples to really take up health humanities as a challenge and claim that territory. Because issues are critical, you know, a race-critical public health agenda, health justice, Indigenous methodologies when it comes to assessing, you know, speech and language difficulties for Indigenous children. You know, there's a rich intellectual space in which we could claim that reveals the limitations of both humanities and health. Because I don't trust the anthropologist of culture either. I mean, that's pretty violent. But as Indigenous scholars, we could take a bit from here and a bit from there and lay claim. And really lead the way in new knowledge production rather than reproducing the system that's been violent to us and being alibis for it, or being the black window dressing that makes it somehow acceptable.
So the point that you brought up is really fascinating. And I think oftentimes cultural competency has turned into cultural stereotyping. And I remember walking into a room where folks really want to do well for the Muslim community in Michigan. And you know, literally on the list was like, you should greet with Assalamu alaikum. I was like, please do not do that. And it's an interesting point, right? Because these become practices and stereotypes. The questions that you ask lay in all the points that you made about what is the stereotype I have of my Indigenous patient or my Muslim
competency is
patient.
always about whiteness. When we teach cultural safety, cultural competency, it's all about the culture of white folks.
Well, it shouldn't be.
We're teaching them about themselves, though, about their own culture, because they claim that they don't have one. They do, and it's violent.
I mean, one of the other wrinkles in the story here is about for us is our Māori students and our Māori workforce who are all at different parts of their own journey around their Māori identity. Access to our language. So one of the things that can happen is that there's an assumption made that if you're a Māori student, oh, you're an expert on all things Māori. So like many of my colleagues, I'm sure we've had the experience of, you know, whether it's on a ward round or in a lecture theatre or in a tutorial, somebody saying, oh, you know, tell me what the most important things are about Māori health and how we need to fix it.
Yeah.
So I'm also really interested in taking care of our students and making sure that their journey is a safe one and that they're not put in positions where they are expected to deliver, let's say, the karanga, the call, or karakia, prayers, or stand up and speak on behalf of people when in fact that is not their role, that they need to be looked after. Because there's an assumption that if you're Māori, oh, you're going to be the expert on all things Māori, and that's not certainly not the case.
And you know what's interesting too is one of the questions Abdul asked us when we were getting ready on cyberspace, if meeting each other and figuring out what we were thinking, was the role of Indigenous leadership in all this. And what I find fascinating and sad is the absence of the ability to just be a medical student, to just be an Indigenous physician, to just be an Indigenous surgeon, to just be an Indigenous researcher, because you are expected to, if you are an Indigenous physician, you are expected to be on every committee at that university to drive everything from the curriculum to cultural safety and humility to the Indigenous student that is, upset about, like, it's amazing. And then all of a sudden you're an Indigenous researcher. All of a sudden, as a junior scholar, I'm on the governing council of CIHR trying to decide how to spend their billions of dollars and where it should go. And because you're pulled into all these directions, you're asked to play these public roles. You're asked to be on, run for government. You're asked to, it's amazing, and it happens so quickly, so suddenly. And I would say my non-Indigenous friends, even my non-Indigenous mentors, say that's an amazing opportunity, you should take it. Whereas my Indigenous colleagues, and particularly Indigenous mentor, would say, give yourself space. Like right now, you're actually a fourth-year medical student. You really shouldn't be taking on the government on Indigenous admissions policies. You really shouldn't be banging on the door of the university president and explaining why this is a massive issue in the medical school curriculum. But then at the same time, you're like, but that's my responsibility. And so how do you protect the Indigenous scholars that are behind you, the potential Indigenous scholars, and make it a path that is rewarding and that you don't necessarily have to take on the world.
Correct.
To be successful.
And I think that's quite a large problem in Australia, because we only have a very small population. Very small population in the academic arena. But so, when you come out of your PhD, most people come out into a professorial position.
But not all.
Not us, Chelsea. So I think Chelsea and I and a couple of others are probably the only ones that didn't take that path, but the opportunity's there put for you if you want to. But then they turn around and say, well, they can't take care of their own affairs, because they've literally set you up to fail. You've come out as a PhD student in a professorial role, you don't know the system, you don't know this, you don't know that, and then they say, oh, look at them, they can't do it. So that's a pretty big
And I
problem.
think for the Indigenous women in the academy as well, I joke about turning off the lights and mopping the floor. There's a lot of invisible labour that's left to Indigenous women in the academy in terms of pastoral care for students, stuff that you can't include in your academic portfolio when you go for promotion.
That's right.
So that other bit at the end of the academic portfolio tends to be me laying claim to all the invisible labour that keeps me there. Gets me there at 7 in the morning, keeps me there at 7 at night while raising 5 children and running a community NGO. And being 10 times better than, because apparently if it's 10 times better, we'll break even though we know that's not true.
Yeah.
There's a violence around that in terms of what the Academy does to the Indigenous scholar. And so I think there's part of, we also need to be calling that stuff out. And also the protection of
not just students, but the researcher and the academics at the university. You start to teach students about the past history, mention Aboriginal, and the violence that raises in the classroom is quite incredible. So it's something that also needs to be looked at.
We did some work recently around teaching while black, and I know in the US there is a discourse around that, but in Australia there isn't. And so it's any student resistance to Indigenous content in the health curriculum is deemed we're not experienced educators. There's something wrong with our a pedagogical approach somehow. And so we carry the blame for white resistance to black truths in our own country, in our own disciplines, and that stuff needs to be talked about more.
So I really appreciate this, and I don't want to interrupt the discourse, but I do want to open the floor up for questions from the audience, and I see one hand over here.
Thank you. Thank you very much. This has been awesome. I'm still processing. First part of the question is, this is an all-female panel. Please comment appropriately. I have my own thoughts, but I'll share them. The other thing is trying to figure out the path of allies. Had a couple of things about that. I was reflecting on the example I might have from my own life of helping other women, other LGBT folks in their careers. And I'll just promise you this, we can block and tackle for you. We can be sure you get the mic without asking for it ourselves. And we can be sure that we examine all situations for tokenism, and we can stay out of your way and do it for yourself. I think that's the real empowerment. So, though you may not even want us to do that, I'm saying there are those of us who are willing to do that, and there are examples from other struggles that but I'm merely interested in all-women panel, please comment.
Can I just, in terms of the ally, I'm not discounting the importance of allies. We're 3%, we rely on 9% of the population to kind of grant us anything. Even if we're all in solidarity, 3% is not political power. I encourage people to think about the power of an angry white woman and what they can do. Because I can be an angry black woman and ask questions and pose problems, but I'm an angry black woman. But outraged white women can change stuff. Like, seriously, like people listen to them. So to encourage not to be passive in activism as an ally, to be the person that at the table that says, hang on a minute, this is not right, rather than relying on, you know, black labour or Indigenous labour to do that work, because it's exhausting for us doing it every day. So, yeah, I'm a fan of allies in terms of, but get angry and be that angry person at the table so we don't have to all the time. But in terms of the female representation, I think there's a presumption that in Indigenous context that the patriarchy works in the same kind of way. And my experience in my community is we run stuff. And gender operates differently, and not to dismiss that, you know, patriarchy came on a boat too, and, you know, we've had to experience that and endure that. But I think, yeah, gender doesn't always work the same way in Indigenous context as it does in a Western sense. Not to say that we're kind of isolated from that, but it's a bit more complicated in terms of how gender relations work. And so black men can speak about gender oppression in a different kind of way than what a white man can. And so I'm conscious of that also.
Yeah, I agree with the comments about finding our natural allies. We have a law in New Zealand, the Health Practitioners Competence Assurance Act, which requires all health workers to be competent to work with our people, which would suggest that there's some sort of baseline level of awareness and skill and attitude that is positively attuned to our needs. The reality is that's not been my practice-based experience. That being said, I think one of the fundamental ways to create more allies is to teach our real New Zealand history in our school curriculum and to create a bilingual society. So if we could all speak Te Reo Māori, and we do have a lot of uptake actually of Te Reo Māori from our non-Māori community right now. There's been a real resurgence of that. So I think those things do take time, but that's going to be where the authenticity and the sense of support for people who want to ally with us and want to come alongside, for them to feel strong in that role. I think that's where that's going to come from. In terms of being an all-female panel, I don't know what the perhaps original ideas were from the organising committee. I don't know if they approached some Indigenous men and they weren't available. Possibly, you know, like we are very busy in our Indigenous communities, and our men have certain roles and we have certain roles. I know that my partner, who's from Ngāpuhi, would probably say, oh, bloody good having a whole lot of women there, because the women actually do the work and get things sorted out. Yeah, I suppose we are in Māori society used to getting, you know, rolling our sleeves up and getting on with the job in hand, and maybe that's why there are 4 women on the panel today. But ko e take te mana o te tangata. One of our other sayings is we don't stand on the status or reputation of others. So I certainly don't want to say anything in any way to anything negative about our men. I feel proud to be here as a representative of all Māori whānau, all Māori families. Kia ora.
Yeah, I really appreciate the question. I think that I would just echo, if the question was put to my community in terms of how are we going to include Sagmock First Nations health, the room, it would look very similar. There'd be, 20% men and 80% women. I think that's just our community. What you articulated, I wish I could bottle it in terms of how you see your role as an ally and what you aim to do. The role of tokenism, of giving the microphone, of not taking the microphone if we're not asking to take the microphone, of wanting to be an ally. And I think one of the things that I have found over the years is that there's people that want to be allies that you can see a mile away. You can feel their heart beating. They are just so passionate. They care about the outcome as much as I do or my community does. And then unfortunately, there's another type of ally that in a way I think I'd rather just have a non-ally. They're the people that see opportunity. They're the people that see the 5% money put aside for research and see a great opportunity for a grant and have good intentions. They do want to address the alcoholism in the Aboriginal population, but their heart is perhaps in a different place, and the partnership isn't there, and that they haven't spent the time to create that trust. They don't understand the requirement and non-negotiable relationships that must be present, and then they can do danger and they could do harm very quickly. But what you said, if I could bottle it, because I could feel it from here.
Yeah, kia ora.
Chimequich.
Yeah, I think as to the gender issue, I'm not sure how that eventuated at all. But I think that it raises a couple of difficult questions for me. Now, I have a lot of allies, for obvious reasons. We don't have the population to be able to do it all ourselves. They're fantastic people. I think it's that feeling that you have in your heart. Those allies are most often people who have experienced some form of oppression themselves, I find. But I think at the same time, we need to ask for those allies, I guess I'm trying to say, because I'll give you an example. They're doing a national evaluation of the funding for Indigenous primary health care. Now that tender was won by a New Zealand consulting firm, a white New Zealand consulting firm. They've employed a number of people, other white New Zealanders. Guess who's doing the work? And it's not them. Do you know, it just doesn't work, and it just brings a lot more work to us. So I think be careful about how people think about that. Yeah, and I can't tell you the number of projects I've tried to salvage for people. And that's in the interests of the communities they are working with, not in their interests at all. So I think it's a really difficult question, yeah.
So I think unfortunately that's the time we have for the formal presentation. I want to thank you so much. If we can have a round of applause for this incredible panel. And I deign to speak for anyone, but I presume that you will be around, and if there's an opportunity to ask any questions that weren't asked, I hope that you'll take that. And thank you so much.